A very beautiful morning to you. Thank you so much for tuning in this amazing Tuesday morning. I hope you're doing well today. You're feeling great today, at least. Bad as a bad. Heat, not to worry. Hopefully, rain fall where you day. All right, so you can hear from my voice. I was able to sleep well small. Because the rain came and it overcame the heat. So I'm quite grateful for the rain today, honestly. All right, so I hope that you're feeling great. You're feeling good today, being a Tuesday. Today, the 20th day in the month of February 2024. All right, so you're welcome to the program Radio Doctor right here on Women Radio WFM 91.7. My name is Rose Yusuf Kaiser, and of course, this is the program Radio Doctor, your free health consultation program where real doctors advise real people. Radio Doctor is Nigeria's first specialized health program where medical doctors consult for free and advice right here on Women Radio WFM 91.7, which comes to you Monday through Fridays, I beg your pardon, from 10 a.m. So today's on Women's Health on Radio Doctor. Yesterday we started off with Children's Health. Today, of course, it's on Women's Health, and Women's Health on Radio Doctor is supported by ACT Foundation. All right, you're welcome once again. Today, our Radio Doctor is Dr. Colin Saboloje. He's an assistant medical director and fertility physician at St. Ives Specialist Hospital. All right, good morning, Dr. Saboloje. So good to have you on the program today.
Good morning, Rose. It's nice to be here again.
All right, so excited to have you today on Women's Health. So, the phone lines will be open shortly for you to call in and let us get your thoughts, your questions, and your concerns on our topic of discuss today. So, Dr. Saboloje will be consulting and advising on adenomyosis. All right, adenomyosis. I hope I got that right because I've been struggling with this word since yesterday, but we'll get used to it. We'll get used to it. Thank you so much for joining us this morning. So let's not forget that Women's Health and Radio Doctor is supported by ACT Foundation. The phone lines are 07000 917 917. That's the number to call. Send us a text or a WhatsApp message on 070 317 56537. Follow us on our social media platforms: Facebook, Instagram, X, and of course YouTube at WFM 917. Listen live on our website www.wfm917.com. Download our mobile app WFM 917. So let's head on to the discussion of today with Dr. Saboloje. All right, so let's start off from the very foundation. Let's give our listeners what they need to know about this particular topic of discuss today, because definitely having fertility experts with us this morning, this is definitely something that maybe most women will be dealing with, but we don't even know what this is. So kindly give us a background on this, on adenomyosis, and then from there we'll pick it up. We'll pick the conversation from there. But first of all, let's know what this is. Let's know how it affects us, and let's know how we even come about this in the first place. Over to you, Dr. Saboloje.
Okay, thank you, Rose. So, adenomyosis is a condition. It's a benign uterine disorder. Okay, that is characterized by the presence of the endometrial epithelial cells and the glands, okay, in the muscle, in the myometrium of the womb. Okay, so now let me just let me break it down, okay, because I think these are medical grammar, so a lot of people can actually be able to understand. So basically, what happens is that the womb, okay, has three parts. It has the outer part called the perimetrium or the serosa. It has the myometrium, which is the muscular part of the womb, and then of course that is a part that of course hypertrophies, it grows big, it expands to make sure that of course the womb is able to carry a baby, okay, and of course that is the point from where the contraction starts, okay, and then when a woman is pregnant, okay, and then of course we have the internal part, okay, that internal part is called the endometrium. Last week we discussed, 2 weeks ago, we discussed endometriosis, okay. So adenomyosis now is what we call internal endometriosis. Now what this means is that those cells that are present within the inner part of the womb, the part of the womb that bleeds, okay, during menses, the cells that are present within that space called the endometrium, they are now found in the muscle of the womb. Okay, normally they shouldn't be there. They should only be present inside of the womb. But now they are present in the muscle. It's just like having something grow within someone's muscle. Okay, they shouldn't be there. Of course, that will cause problems. It will bring about pain and other loss of certain functionalities. And this is the same thing that would happen to the womb when these endometrial glands start to grow or are present inside of the muscle of the womb. It is said that this condition is present in about 20% of women that are under the age of 40. And of course, 80% of the cases of adenomyosis, of course, that have been recorded are found in women after the age of 40 years. And it is a disorder that has an increased risk of infertility. So it has this predisposition to causing infertility. And it also has a high predisposition to causing pregnancy losses or miscarriages, and of course preterm labor. It is a condition that is estrogen dependent. Now what this means is that as long as the woman keeps seeing menses, the condition keeps getting worse. It keeps progressing from one stage to another as long as she keeps seeing menses. Okay, it has been classified into superficial and deep type, or what we call focal and diffuse. Focal is the one that is just resident within a portion of the womb. It's benign, it is well circumscribed, but it's resident there at one portion of the womb. While the diffuse type is the one that is expansive. It has spread throughout the muscle to a large area of the womb itself. And with respect to the type of the adenomyosis, the symptoms that the woman will experience, would vary, okay, with respect to the type, whether it is focal, whether it is diffuse. Of course, some people who have diffuse adenomyosis, they will experience more severe symptoms, and of course they are more predisposed to even having all this preterm labor and all of that. And the truth is, they are more likely to have infertility than even people that have the focal adenomyosis. The good news with this condition is that people can still get pregnant with adenomyosis compared to endometriosis, that up to 50% of the women who have endometriosis will find it difficult to get pregnant. The numbers are less for people with adenomyosis. So you can still find people around who have adenomyosis and they get pregnant and they still carry their babies to term, irrespective of whatever science have shown, whatever studies and research have shown that, of course, women who have adenomyosis have a high risk or high chance of having miscarriage. You can still find people giving birth naturally, getting pregnant naturally, getting pregnant through IVF, and also carrying their babies to term and delivering. So it is it's a more forgiving condition, okay, compared to endometriosis.
Okay.
So Go
ahead.
So that's that.
Okay.
Okay, I actually wanted to just talk about some of the risk factors.
Yes, please go ahead. I was about to ask you that too.
Okay, what are the things that might actually so the truth is, for women who are above the ages of 40, okay, they have a high chance of actually having this condition, adenomyosis. And then for women who have given birth multiple times, okay, they also have a high risk of having this adenomyosis. And of course, for women who have had surgeries before, be it cesarean section, D&C, hysteroscopic surgeries, they also have a high risk or high chance of also, of course, developing this adenomyosis. The truth is, there are certain theories that have been postulated that are the cause or the reason why people would develop adenomyosis. The first, of course, is the postulation is that there is an invagination. When we say invagination, it's like turning something out, inside out. When something turns inside out, like if you have your pocket, you have to turn it inside out, bring it out. So that is what it means. It means that inner space of the womb, called the endometrium, the basal layer, okay, it has two layers. It has the basal and the functional layer. The basal layer is what gives rise to the functional layer. The functional layer is the part of the womb that sheds, that bleeds when you see your menses. The basal layer cannot shed, because if the basal layer sheds, then that means that the woman, of course, will not be able to see menses again, because that is what gives rise to the functional layer that sheds. So what happens in this is that, according to the theory, it states that basal layer actually turned inside out to face the muscle and started growing into the muscle of the womb. So that is one of those layers. That's one of the theory. The second theory is that due to injury, now this is the part of people that have had surgeries before, due to injury of a zone, we call that zone the junctional zone. It is the junction between the inner space of the womb and the muscle. It is like an area that separates that inside space of the womb and of course the muscle. So it's called the junctional zone. That junctional zone, the theory says that due to injury of that junctional zone, due to reparative process and all of that, and all the invasion, movement of the endometrial cells, glands and cells and stroma, from the inside of the womb into the muscle. That is another theory. Another theory, of course, also states that it's due to embryonic development, that due to the development of the child inside of a mother's womb, that is how there was some misplacement of things, and this is what will predispose the woman to having adenomyosis. So basically, like I said earlier, these conditions, usually adenomyosis and endometriosis, they usually have theories that will support their presence in people, and why certain people are predisposed to having it. With respect to endometriosis, for that, it is people who have never given birth before, people who had unperforated hymen. These are the people that are predisposed to having it. But in this case of adenomyosis, it is people who have given birth multiple times. Okay, people who have had surgeries in the past, and of course women who are between the ages of 40 and 50.
Okay, so women between those ages are the ones more susceptible to this.
Exactly.
Okay.
According to what the studies show.
Okay, so thank you very much, Dr. Bolaji, for that. This is Women Radio WFM 91.7, 18 minutes after 10. Do well to send in your questions and, of course, your concerns and your thoughts on the topic of discuss today. You can do that via the number 07000 917 917. Send us a text or a WhatsApp message to 070 317 56537. Those are the different numbers you can get in touch with me this morning, and of course the doctor too is here to hear from you. All right, so today is Women's Health on Radio Doctor and is supported by ACT Foundation. So do want to call in. Let's get to hear your thoughts, your concerns and your questions on adenomyosis. All right, this morning adenomyosis. I just I don't know, my tongue keeps twisting when it comes to this word. All right, so let's head on to it. Dr. Bolaji, now you've given us a background of this, and of course you went further to give us more explanation on this. Now let's look at the symptoms that comes with this. All right, so what are some of the symptoms associated with this, and how can this actually, I know you've mentioned it, but how does this affect conception? But you said for women who are 40 years and older, they are the ones more open to this. But when you look at that age, some women, let me not say most, some women have probably done giving birth and they're just trying to raise their kids. So does this still get to affect them or stop them from having any form of reproduction even after maybe they feel we're done, we're okay, and we just want to face on and get on with life? All right, what are some of the signs and symptoms that comes with this, and how does it affect women in that age group?
Okay, so now for the signs and the symptoms, they will be present in both people who are who are below the ages of 40, and also for people who are also above the age of 40. Okay, so and it's just that it is more prevalent. This condition is more prevalent in women that are above the age of 40. So, but for 20% of the cases of this adenomyosis is found in women that are under the age of 40. Okay, so these symptoms are going to be the same in both age groups. Okay, so the symptoms are also the same as the ones present, well, just with a few exceptions. They are very, very similar to the symptoms that you would experience in a patient that is having endometriosis. Number one, the first symptom will be painful menstruation. We call it dysmenorrhea. This is pain, excruciating pain during menses. For some people, they could even have this pain. The pain could even start before the bleeding starts. Okay, and for others, it would start maybe when the bleeding starts and even progress even until after the bleeding stops. So this is dysmenorrhea. It's painful menstruation. And this actually occurs because of the increased amplitude, the rate at which, because of the presence of this adenomyotic focus on the muscle of the womb, it will make the muscle to hypercontract. We call it hypercontractility. It just hypercontract, like as if it is spastic. And because of that, the woman starts to experience excruciating pain during menstruation. Yes, there's some level of cramping that will be experienced in women who do not have it. I don't want to have to use the word normal women, but I want to say women that do not have adenomyosis or endometriosis. Some women have some small level of contractility, and this will express as small cramps here and there. Okay, that is very, very normal. But for this case of adenomyosis, it will be excruciating cramping, excruciating pain during menstrual bleed. And of course, there will be painful intercourse. So such a woman will find it very difficult to have intercourse, because that will definitely repel the woman from even wanting to have intercourse with her hubby. So getting pregnant, of course, will still be affected.
Yeah.
Now, in this case, because of both the psychological effect of, that pain, what the pain does. So it repel the woman from even wanting to have intercourse at all. So the next, of course, is heavy bleeding. So women with adenomyosis usually have heavy bleedings, and this actually occurs because of the expanded surface. Now, you find this endometrium, the endometrium, which is the inner space of the womb, it bleeds, like I said earlier. You also find that those cells, those glands, okay, also present in the muscle of the womb, and these areas also ultimately still have some bleeding, and so it's going to be so because of this, the woman will be having heavy bleeding. And then for some people, they would have what we call prolonged bleeding. We call it metrorrhagia, where they bleed beyond the normal days. On the average, most women will bleed between 3 to 5 days during their menstruation. But rarely you see women who bleed for 7 days. It is still normal, okay? But then the moment it starts to extend beyond 7 days, then you already know that this woman is actually having prolonged bleed, and this can also be a sign, okay, of adenomyosis. And then for some people, they will be having low, we call it anemia, which is low blood level, as the public would say, or as the layman would say. Okay, it simply means that the blood level of the woman will get low because of the bleeding, because of the heavy bleeding pattern that she exhibits every time she sees her menses. So this will also would translate to a reduction in her blood level. For some people, they would also have low back pain. Okay, so they will keep having low back pain even when they are not seeing their menses. There's always pain at the back. Please, this is a disclaimer. Don't think that every low back pain points to either the woman having endometriosis or adenomyosis. No, but these are the symptoms that are present. Sometimes symptoms are present and they mask each other and they mask different conditions, but they actually will not be what they seem.
Okay.
And yes. So, and then of course you find people also having a delay in getting pregnant. Now this is infertility. They'll have a delay in getting pregnant. So the second part of your question was with respect to how it causes infertility in people. Now, generally, this condition, what it does, first of all, it affects the transport of sperm. Okay, due to there's something called this junctional zone, like I explained earlier, which is a zone between the inner space of the womb and the muscle. It is a zone between the endometrium and the myometrium. Myometrium is the muscular part of the womb. Endometrium is that inner space of the womb that bleeds during menses. Okay, so there's a junctional zone present in between. It's like a band of, let me just use the words, like a line, an area. Okay, just round about, differentiating that endometrium and, the myometrium. So basically what happens is that due to the hypercontractility that is present from, that is spanning from this junctional zone, of course, it will prevent the sperms from moving to their, to the tubes to try to fertilize the eggs. Because like I said, in this condition, you still find a lot of people that are getting pregnant naturally. So the fact that the woman has adenomyosis does not translate to absence of ovulation in the woman. So the woman can still ovulate, but because of this hypercontractility, of the muscle, and of course the problem with the junctional zone, the sperms will find it difficult to, get to the tubes. Another thing is that this adenomyosis itself, when a person has the focal type of this adenomyosis, it surely would look as though the woman has a fibroid. For most people, it's after they've gone in for fibroid surgery, they open up and then they find out that this is not actually fibroid, it's actually adenomyosis. And it's usually mostly confirmed by pathologists. So basically, the tissue will be removed and given to the pathologist who will check and let you know that this is an adenomyosis. Of course, these days it is easier to diagnose. This is just to digress a little bit. In the past, it used to be, they remove the womb and then do a biopsy and then now check to see that this is actually adenomyosis and it's not something else. Okay, so that is the first way. It prevents the transport of the sperm for its onward journey to the tubes to fertilize the egg. The next thing is that because it looks like a fibroid, sometimes the location where it is present in the focal type, it will compress and it will block the opening of the tube into the womb. So because of that, it will be acting as a pseudo blockage, so to say, causing more like a blockage, preventing sperms to move into the tubes. The next thing is that the presence of this adenomyotic focus also produce certain inflammatory substances like interleukins 1 and tumor necrotic factor. These are some pro-inflammatory substances that when they are produced, they will cause inflammatory responses that would, of course, make that environment of inside of that womb to be unconducive for an embryo if the sperm was able to actually get to the tubes to fertilize the egg and become an embryo. So it makes that the space, the final residence of that embryo, it will make it very unconducive for the growth of that embryo. Secondly, it also prevents implantation due to also the secretion of certain substances. There are substances, usually when a woman ovulates, when the sperm moves over to the tube to fertilize the egg, it becomes an embryo, and then it moves back into the endometrium to implant, more like attach, So we call it implantation in medicine, So what it does, there are certain substances that mediate that implantation. There are certain substances that have to be present. They are adhesive substances. Just take them, liken them to be a glue, that will be present inside of that endometrium that would attach the embryo, that will make the embryo to easily attach, easily implant. So what adenomyosis does is that it prevents the or it prevents the makes those substances to be produced in little quantity, and as a result of that, or even prevent them from being produced at all. So because of that, the embryos will find it difficult to implant in the woman. So infertility, of course, will be the case, difficulty in getting pregnant. And lastly, it also prevents the growth and development of even embryos within that space. So these are the ways in which it prevents a woman from getting pregnant. Exactly. So the last question you asked was about the people that are present within the age of 40 and 50. And just like you rightfully said, you said that, of course, these women, of course, between the age of 40 and 50, they already have very diminished ovarian reserve. So basically, their fertility potential is already reduced. So for them, actually, getting pregnant might not be the case for them. Exactly. So it may be to for them, their own thought to be symptom amelioration. Why are they having all these symptoms? They want a better quality of life, because most people within the ages of 40 and 50 have already given birth. So, but they just keep on experiencing this symptom because they keep on menses, like I said earlier, because the condition is estrogen dependent. So for them, the way to handle their own case and whatever they will be telling you will be talking about symptoms mostly. But for women who are under the age of 40 and the women that will be telling, doctor, besides these symptoms, I have not been able to get pregnant too. So you already know that their own is both the overexpression of this and the severity of the symptoms that they're experiencing, plus difficulty in getting pregnant. So I don't know if I've left anything out. I'm trying my best to, tick all the boxes. So if there's anything, please.
All right. Thank you so much, Dr. Bolaji. But one question that keeps coming up to my mind is, so what's the distinguishing factor of between adenomyosis and endometriosis? Oh my goodness.
Endometriosis.
Yeah. So what's the distinguishing factor between these two?
Okay, so endometriosis, is usually these days it is we will call it like a systemic condition. Now I will tell you why. Because in endometriosis, the the endometrial tissues, and the cells and all of those things, they are present in different structures. They can be present on the bladder, on the rectum, on the lungs, in different areas of the body, on the ligaments. But for adenomyosis, it is Adenomyosis, we call it internal endometriosis. What it means is that those endometrial glands, they are not found anywhere else. In the case of adenomyosis, they are found in the muscle of the womb itself, the muscle of the womb. But in endometriosis, those endometrial tissues, they are found in other ectopic organs, distant organs. The bladder, found on the bladder, found in the ligament, found on the wall of the abdomen. In fact, on some people, they will be having lesions even in their umbilicus, okay, the place we call the navel, okay. So they'll be having endometriotic lesion there. So whenever they are seeing menses, that umbilicus will be bleeding. Yes. That umbilicus, the navel will be bleeding, will be bringing out blood. When the menses stop, the blood from that navel will also stop. So that is what endometriosis does. It deposits this tissue in distant organs, in distant areas. It could be even under the skin. For some people, to be formed as a form of nodule close to the inguinal regions, close to this bikini line, So for some women, you see that's like a hard structure underneath the skin, But this is not the case for adenomyosis. In adenomyosis, it will look like a fibroid. In people that have the focal type, okay, it will just look like a fibroid. So the woman will be feeling like a bulge on her tummy, but that bulge in this case is not a fibroid. It's actually the womb that has become very big because of the continuous hypertrophy of that muscle, of the muscle of the womb. So in adenomyosis now, it is not present anywhere else. You cannot have adenomyosis of the bladder, okay, but you can have endometriosis of the bladder. You can see the relationship now and the differences. So you can have endometriosis of the where now, okay, maybe of the peritoneum, but you cannot have adenomyosis of the peritoneum. No, the adenomyosis itself is restricted to the womb. It is present on the womb. It's present on the muscle of the womb. So that is the difference. So, and of course, with respect to symptoms like bleeding from the navel are not present in adenomyosis. Okay, so these are some of these differentiating factors. And endometriosis can be really, really serious. It's a very serious disease and can really be very, very troublesome. It doesn't even give space for the woman to get pregnant easily at all. But in adenomyosis, the woman can still get pregnant easily because the woman, in most cases, will still be ovulating, especially if she's within the ages of women that can still ovulate. But in endometriosis, you will find a cyst present in the ovary, preventing the growth of any other follicle. So it's something else, honestly. I must say it is really troublesome. Endometriosis is troublesome. So these are some of those differences.
Okay. Yeah. All right. Thank you very much, Dr. Bolaje. This is Women Radio WFM 91.7, 27 minutes to 11 right here. Do also send in your text, your WhatsApp messages to 070 317-56537. All right, that is the name of that is the number to get in touch with us this morning. 070-317-56537 for text messages and WhatsApp messages. 07000-917-917 is a number to call in this morning. All right, so let's get to go on. This is Women Radio WFM 91.7, and of course, this is the program Radio Doctor, your free health consultation program, where real doctors advise real people. Our Radio Doctor is Nigeria's first specialized health program where medical doctors consult for free and advice right here on Women Radio WFM 91.7 that comes to you Mondays through Fridays from 10 a.m. And today is on women's health, and it is supported by ACT Foundation. And today we have Dr. Colin Bolaje, an assistant medical director and fertility physician at St. Ives Specialist Hospital. And today he's consulting and advising on adenomyosis. Yes, I think I got that. All right, so do well to send in your questions, your text, your questions, your concerns through text or WhatsApp messages. All right, Dr. Bolaje. So now we've heard a lot about this, and it's actually good. Sometimes after Radio Doctor, I get to feel like someone who is going to part-time medical school. From here, because even if even if I don't experience all of these things, but at least I have information that when somebody asks me, I'm able to give answers to some of the questions that are being asked. So I find myself educating people. So that's one important thing about Radio Doctor, and I think I definitely love. All right, so let's look at
So actually, sorry, I just wanted to say something.
Okay.
Honestly, there's something, because I listened to the radio doctor program last week, and there was a question you asked Dr. Edopolo about uterine adhesions. Honestly, the moment you asked that question, if the doing the pap smear procedure could actually result in formation of uterine adhesions, I was like, oh my goodness, like you're actually listening. You are, even though you are the presenter, even though you're the moderator, you're actually listening and you're taking notes, because for you to have asked that question, then it meant that all the things we've been saying actually they are sinking inside of you. So yes, just to buttress on the point that you said that you're actually looking like a mini medical student. Oh yes, you are. I must say.
All right, thank you very much, Dr. Wilije. Thank you so much. All right, so now let's look at the diagnostic tests that are commonly used to confirm the presence of this in patients, especially for those trying to conceive. So what are some of the diagnostic tests that have been done, to confirm the presence of adenomyosis in patients, especially those who are trying to conceive?
Okay, so basically the very first test to do is a pelvic exam. So basically you want to examine the woman because, like I said, because this condition sometimes can be likened to having a uterine fibroid. Okay, so the woman will be having a bulge in her lower abdomen. She feels that there's something solid, so to say. Okay, and that solid mass that she usually would feel is actually the womb, because it has grown very big to be bulky. We call it bulky uterus in our practice. Okay, so, and this is because of this growth, the hypertrophy of the muscle and all the whatnots of adenomyosis. So basically, the moment you're examining the woman, you're already seeing that. And it doesn't stop there, because when you examine a woman with a mass in her tummy, especially for a woman who has come to a fertility clinic or to see the gynae, the first thing that comes to your mind, first of all, is maybe uterine fibroid. So it doesn't stop there. So you have to now confirm what you're actually feeling, okay? Because that is a feel. You do examination, palpation, and all of that. So you have to now confirm it by doing an ultrasound. An ultrasound in this case has up to 86%. Okay, of accuracy in diagnosing adenomyosis. Okay, unlike in the case of endometriosis, where you would have to use the laparoscopy, okay, and or an MRI. They give a better better feedback to you, when you're trying to diagnose endometriosis. But in adenomyosis, ultrasound can actually help you, just a regular room ultrasound. Okay, you do that, and then you're able to see some of these things like myometrosis, the presence of heterogeneity, in the uterine image, globular uterus, and all of that, So, and of course, the next diagnostic modality that is used is the MRI. Okay, so the MRI usually will show us a widening of the junctional zone. That junctional zone should be less than 8 millimeters, but in the case when you do an MRI, you find out that the junctional zone is increased. It is thickened. We call it thickening of the junctional zone. So it becomes thicker than 8 millimeters. And okay, so that is present in both the focal and the diffuse adenomyosis. And then lastly, for diagnosis, of course, some people would go on to also use laparoscopy to diagnose this condition, because when you're seeing the uterus, you're seeing that bulkiness and all of that, And then, but lastly, okay, and this was the mainstay of diagnosing adenomyosis in the past, and it's a pathologist post-hysterectomy assessment. Now, what this means is that usually in the past, this condition is
Dr. Boleje, let me just pause you for a while. We have a call, just a few minutes. Hello, good morning.
All right.
Good morning.
Hi, good morning. What's your name? Where are you calling from?
I'm Maria, calling from Kurudu.
All right, Maria, you're welcome. Let's hear you.
Okay. Hey, please, I want to ask. In 2020, I have surgery. I was pregnant with 6 months pregnancy, but unfortunately, we lost it to fibroid. So, 2022, I got pregnant again. So when I was in the theater, the doctor said that he asked me how many kids do I have. I said I don't have none. So he was telling me that my womb is light. So now my baby is about a year and 6 months, and I'm trying to conceive again. Is this dangerous for me or not?
Okay. Maria, could you just please let's hear you again, because I'm also trying to understand what you're saying. I know you said the first time you had surgery, you were 6 months pregnant, and then the second time also
was 2022.
Okay. So you were asking.
So when I was yes, sir. The doctor told me that my womb is light.
Light.
Yes.
Okay.
That if I not have another child, I start from the one that was giving birth then, that maybe I have to try once again. But I would not allow the pregnancy to come to the day of delivery. I should not have delivery pain.
Okay. All right.
Okay, for me now, so my question is that should I put myself in that risk or I should give up?
Oh, okay. All right. So, Dr. Bolaji, did you get her question well?
Yes, yes. So I got the question, but I am still finding it a little bit difficult to what to make of the statement, the womb is light.
Right.
But I think what I feel is that means is that she has a womb that is prone to rupturing. Okay, if she should go into another labor. So the thing there is that now for her, okay, she has to now, because she's done a surgery before, according to what she said. So the truth is, for people who have done surgeries before, okay, sometimes they give them a little bit of time, okay, so that to prevent them from getting pregnant for a period of time, because if they are to get pregnant just shortly after the last one, especially because they did surgery, okay, it will make the womb prone to rupturing. As the baby grows, the womb can rupture, and it will be more for people, of course, who would have who would go into labor. So for her, I think she has a particular predisposition to having uterine rupture, and it could be maybe because of a particular condition, which of course I'm not so sure about her, because the doctor that has told her that her womb is light should be able to explain better.
That, yeah.
I know we use some of these words to be able to relate to the client, who of course is not the medical practitioner, but I think sometimes I think the medical name of whatever he meant should also be told to the woman, so that when she's saying it to somebody else, she's able to mention that condition, and then it will be easy, for any other medical practitioner to relate with, and also to give her also a good advice. But since the doctor has advised, now what he said, okay, according to what she has told us, is that the doctor said she shouldn't go into labor again. So you understand? So it simply means that, of course, there's still a chance that you can still get pregnant, okay? You can still get pregnant, but do not progress to the stage of having labor. So basically, you now be planning for elective cesarean section again. Okay? So that is what that statement might actually mean. But until I get the diagnosis of what it really means by the womb is light, I can't be able to really speak more. But based on what she said now, that's going to be my advice. So if he has said you should stay away from getting pregnant for a particular period of time, I suggest you also honor that instruction. But if he has not said that, if he has only said that you shouldn't go into labor again, okay, you might as well still consider getting pregnant, but book for an elective cesarean section. Okay? So it's a two-way thing. But lastly, I would also still suggest that you go back to that physician and try to understand what it meant by your womb is light and what it means to you, and so that you know what should be done. Because sometimes different individuals, our treatments as medical practitioners can be individualized. What is good for one person might not be good for another person. So you have to know what is peculiar to you.
Okay. All right. Thank you very much for answering, Maria, Dr. Bolaji. So you were still on the different tests that could be used to confirm the presence of adenomyosis in patients who are trying to conceive.
Okay. So the first one, like I said, is pelvic exam. The second one is using the ultrasound. The third is using MRI. Okay, even though it's quite expensive. But the last is, of course, usually reserved for people who have had hysterectomy. Now for women who have possibly, they've given birth, they've completed their family, and then they still keep on experiencing all the symptoms in all the excruciating form that they can present with. So they decide to go back to the hospital, and then of course to get their womb removed. The truth is, the easiest way to get yourself rid of all this wahala of adenomyosis and all of that is to actually remove the womb.
Wow.
If there is no womb, okay, all these painful menses, the menses itself, you won't see menses because it is the womb that bleeds. So there will be no discussion of pain. There will be no discussion of pain during intercourse and all of that. You understand? So that is the easiest way. So we found out that when they removed the womb, they did the biopsy by the pathologist, and then of course he found out that most times they will find this adenomyosis present. Within the uterus. Yes. So
okay, that's quite a lot. That's quite a lot. All right, thank you very much, Dr. Bolojay. 07000917917 is the number to call. Send a text or a WhatsApp message to 07031756537. All right, let's get to hear your thoughts, your concerns, and your questions this morning. Dr. Bolojay is here with us, and of course, he is ready to go ahead and listen to you and advise accordingly. All right, let's pick this call. Hello, good morning.
Good morning.
Hi. Your name? All right, Esther, try to speak up. Let's hear you well.
I'm calling from Ibafo, Esther.
All right, go ahead, Esther from Ibafo. Let's hear you. Oh, okay. Esther's call has gone off. So do what to call back. I think we still have a few more minutes to go. All right. So Dr. Bolojay, our time is fast spent, but quickly run through the treatment options we have for adenomyosis. Let's get to hear you.
Okay. So basically, when we're talking about treatment should actually be individualized for people with adenomyosis, because you want to use certain factors in deciding what is going to be the best treatment for each individual. So for a woman, of course, we want to use factors like the age of the woman, desire to still get pregnant, and of course, the severity of symptoms. But first off, priority, there are different modalities to the treatment, of adenomyosis. Of course, you can use medications to try to improve the symptoms, But the drawback with some of these medications is that while the woman is on these medications, she can't get pregnant, because what many of these medications will do is to actually prevent the proliferation of this endometrium, and this endometrial cells and tissues. So they have what we call an anti-proliferative effect. The first medication, of course, is mainly for pain reduction and resolution, and that is the use of drugs like normal painkillers like ibuprofen, naproxen, even aspirin. The reason is because they help to reduce prostaglandin formation. So prostaglandin is a pro-pain substance. So when you take medication like ibuprofen, they also help to reduce this prostaglandin secretion during the menses, and as a result, the pain will be reduced. But of course, there's only so much that they can do. So that leads us to the next, which of course is called the combined oral contraceptive. Just like I told you, most of these medications now, when you are on them, you cannot get pregnant. So because the way they help you is that they prevent the endometrium from growing. So if the endometrium does not really proliferate, if it doesn't grow, of course the woman cannot get pregnant. But it's only the way to actually help the woman to reduce the estrogen levels present per time inside of the woman, because like I said earlier at the beginning, this disease is estrogen dependent. So you want to use combined oral contraceptives to prevent ovulation, so there will be no much estrogen in the system, and as a result the woman will remain symptom free for a period of time while she's on that OCP or combined oral contraceptive. The next are drugs like progestogens. These are progesterone medications. Two hormones are necessary for a woman to see menses. The first is estrogen. That, of course, is the one that grows the inner space of the womb. It grows the endometrium, and then progesterone comes in to, of course, cause the shedding. But in this case, why you're giving progesterone is to, of course, cause the inside of the womb to remain. So it, of course, will counter the effect of estrogen. So that's why you give the progesterone. Drugs like Dynogest are also used. They are mostly used for endometriosis, but they can also work for adenomyosis to try to cause atrophy thinning of those endometriotic or adenomyotic lesions. And then, of course, you have drugs like danazole that have anti-estrogenic effect. Everything you'll be giving will be to counter estrogen, because estrogen is the wahala. So you have to counter that estrogen so that the woman can, remain symptom-free. And then, of course, there are certain IUDs that contain progestogens also. Okay, that can also be passed into the womb so that there will be continuous production of this progesterone inside of the woman, giving rise to an anti-estrogenic effect. Okay, that's cutting off estrogen, and so the woman will remain symptom-free. Can also help her for the bleeding and help her for the pain. And then, of course, we have drugs like the GnRH analogs. These are the ones we usually use for IVF. So what they do is that they help to, of course, cause atrophy again of these lesions. Okay, and of course, we'll have to reduce the size of the womb. Yes. So, lastly, we have surgery. Surgery is, of course, reserved for people whose medication, who have not responded to the use of medications in the treatment of adenomyosis. So these are the people that you now have to prefer surgery to as a solution. So the surgeries that are open to them is, first of all, they can be what we call adenomyomectomy. This is like doing a fibrous surgery, but it is for the focal one. It's for the focal type of adenomyosis, where the area where the adenomyosis is carved off, and that adenomyotic lesion will be removed. Okay. While for other people, you can do what we call a debulking surgery, just to try to reduce the size generally of the womb, okay, so as to help the woman. And then as a last resort for women, especially women who are no longer desirous of having a child, okay, you have to do hysterectomy, just remove the womb. There's no need trying to go there to cut out any adenomyotic lesion. The woman has already given birth to all her kids, but she's still suffering, having pains during menses for the small period of time that she still has to see menses for before she attains menopause. She'll be having serious pain, even she's unable to have intercourse with her hubby because of the pain during intercourse, and all the other whatnots. So basically, for these people, you have to just prefer hysterectomy, remove the womb, and let the woman go and rest. Okay. So, but like I said, for women who are younger, okay, who are young women who are still desirous of having a child, usually if the medications have not helped them, okay, they have to do surgery, in a bid to try to help them so that they can try to at least have a child and then hang their boots, so to say. So with respect to other treatments, there are some novel treatments that are available right now, one of which is the HIFU, or we call it the HIFU, HIFU, which is high intensity focal ultrasound treatment, where the ultrasound waves are used to try to shrink some of these lesions. Okay, it is still a novel treatment. Not every center does it, and it is quite expensive. Okay. And so basically what they try to achieve is to try to use these ultrasound waves to try to burn out some of these lesions. Okay, it doesn't require the tummy to be open. It doesn't require surgery. Okay, so it is done. The woman goes in there, lies on a particular couch. Some substances are some structures are placed on. Just to direct this ultrasound waves to these lesions present within the womb. Okay. And other treatments also include endometrial ablation, also uses the same principle, but this time it's with direct burning of these lesions. And then lastly, uterine artery embolization. All right. This is where the artery, the vessel supplying the area where that where this adenomyoma is within the womb, okay, will be blocked so as to kill the supply, the blood supply to that adenomyoma, and as a result, the lesion will shrink. Okay, and of course, the woman will remain with to ameliorate her symptoms.
All right, thank you so much, Dr. Collins. This is where we'll draw the curtains for today. But in less than a minute, Doctor, what would you want us to take home today from adenomyosis? What's that take home for us, for you? Just in less than a minute. Okay. Our time is spent already.
Yes, yeah. Okay, so basically, the commonest symptoms that people would experience in all of these, there are two actually. There are pain during menses and pain during intercourse. The moment you start to experience severe pain, there's pain, there's pain. You get what I mean? So the moment you start to experience excruciating pain when you see your menses, it is high time you visited the hospital to get properly checked to be sure that it is not just primary dysmenorrhea, okay, which is the normal dysmenorrhea that most young women would have, okay, to be sure that it is it is not adenomyosis or it is not endometriosis.
Okay.
So prompt presentation to the hospital is key in any medical condition at all. The earlier you catch it, the earlier you resolve it, and the earlier you advise the woman on the best thing to do in a bid to either achieve pregnancy or in a bid to actually help her life.
All right. Thank you so much, Dr. Collins, for being a part of the program today. Thank you so much.
All right. Thank you for having me today.
Have a great day and enjoy the rest of the week.
All right. You too. Bye-bye.
Bye. So that's it today for Radio Doctor. Join us again tomorrow at 10 for another episode of Radio Doctor. And tomorrow is going to be on general health. So today's Women's Health is supported by ACT Foundation. My name is Rose Yusuf Kaiser. Good morning.
WFM 91.7.